So our topic this morning is going to be the spondyloarthropathies. And anything off-label I will divulge as such. Okay. And the objectives I'm going to let you read yourselves in the interest of time. So let's start by talking about the prevalence of the spondyloarthropathies. So there was an analysis done from the NHANES database in 2009-2010 that looked at 6,684 people aged 20 to 64, and they found that 20% of the United States population had lower back pain. It's a high number. More importantly for the topic this morning, 6% were felt to have inflammatory back pain, and we'll define that on the next slide. When you apply a couple of classification criteria that we don't use that much anymore, that being the EMOR criteria and the European Spondyloarthropathy Study Group criteria, you come up with the prevalence of spondyloarthritis in the range of 0.9 to 1.4%. So clearly more common than you'd perhaps think. So these are, in fact, the Assessment of Spondyloarthritis International Society, or ASAS, criteria for the diagnosis of inflammatory back pain. So going forward, it's important to keep these in mind. So you apply them to patients with chronic back pain being defined as present for 3 months or more, and then you apply the following 5 criteria: age of onset under 40 years old, insidious onset, improvement with exercise, no improvement with rest, and pain at night, typically between 4 and 5 in the morning, that awakens the patient from sleep. And if 4 out of those 5 are present, the patient is felt to have inflammatory back pain by clinical criteria. And so, we've been spending an awful lot of energy since the availability of the biologic agents, initially the TNF inhibitors and then the others. We've spent an awful lot of time discussing rheumatoid arthritis, the treatment of rheumatoid arthritis. I gave a talk at 6:30 yesterday morning on the pathogenesis and immunology of rheumatoid arthritis. But we really haven't, I don't think, spent an adequate amount of time paying attention to the spondyloarthropathies. And why do I say that? So if you look at the numbers, and this side of the room, by the way, has gotten short shrifted by all the speakers before me. So I'm going to point over here so no one over here feels left out. So if you look at the numbers, so here's the prevalence of rheumatoid arthritis at about 0.6%. Notice ankylosing spondylitis, almost the same at 0.52%. Yet we don't talk about ankylosing spondylitis as much as RA, by a long shot. And then if you group the spondyloarthropathies, you're up at 1.31, again, in the range of what I showed you a couple of slides ago. So these diseases that we're going to discuss this morning are much more prevalent than we really give them credit for. So, and in fact, clinical practice needs to be looked at as well. So if we're going to say that the axial spondyloarthropathies are roughly as prevalent as rheumatoid arthritis, that is not reflected, I'll bet, in my practice or any of your practices. We just don't see as many patients with spondyloarthropathies as we do with rheumatoid arthritis. And, we're missing them. One of the problems is the referral base, so the internists, the family practitioners, this is really not on their radar. But I think that if any of us in this audience is honest with ourselves, we will admit that we've missed this diagnosis too. And we'll talk a little bit more about that later on in the lecture, but I'll admit that I've missed it. And the reason is obvious. Mechanical back pain is so prevalent that you see someone, it's a muscular problem, it's a disc problem, it's an arthritic problem, a degenerative problem. But I think if we're honest with ourselves, we'll admit we've missed this. And if one of the messages I leave you with today is just to heighten awareness